Thank you very much. It's an honor to be here. I'm amazed at this crowd on a Saturday, so glad to be here. And I'll just say Apokyn is a great drug, so if you have the opportunity to use it, you should try it. We've been using it for a long time now for our patients. But I'm going to talk about something completely different. I'm going to talk to you about non-motor features, and particularly cognitive and psychiatric features. And this is a list of what I'll be covering today. This is just a partial list of some of the non-motor features that we see in patients. But we'll talk a little about cognitive decline, depression and anxiety, psychosis, and if there's time, we'll say a little bit about impulse control disorders. So you heard from Dr. Dewey this morning about the motor features of disease, and the motor features of disease are what define the disease. The disease has always been thought to be a motor disorder that is associated with tremor and rigidity and slowness, but it turns out that Parkinson's is much more complicated than that. And this is a quote on the slide from 2002, which was sort of the beginning of people recognizing the importance of non-motor features, particularly psychiatric and cognitive features. And I'll read it. It says, PD patients' well-being, general health perceptions, health satisfaction, and overall health-related quality of life are strongly influenced by mental health symptoms and weakly influenced by physical symptoms. What that means is the cognitive and psychiatric issues are probably more important to daily function than the motor features are, and probably that's because we can treat the motor features fairly well, and we're still in the infancy of treating these other issues. So we do a comprehensive care clinic in Emory where we have patients come and see several specialists over a 2-day period. And one of the specialists they see is a psychiatrist, and I took some data from the first 95 patients that we had. And if you look at this graph, the thing that really stands out to me is that 80% of those patients have some kind of psychiatric issue. Only 20% did not at the time we saw them. So it's really an important aspect of Parkinson's disease and important for us in relation to treating Parkinson's disease. And you'll see the red bar is depression, which is very, very common in Parkinson's disease. Now, I just wanted to show you the complexity and where these non-motor features fit into Parkinson's disease. There's a hypothesis by a Dr. Brock from Europe who talked about the spread of pathology in the brain of Parkinson's patients, starting low down in the brainstem and then gradually moving up. And you'd be surprised to know that actually the very first stages, which you see now here in red, are before anyone ever has motor disorders. They have other symptoms such as losing sense of smell, constipation, sleep disorders, and depression as very early features of disease. Now we're finally recognizing that these are prodromal symptoms that could tell us that Parkinson's is coming. It's only in stage 3 and 4 that actually the motor symptoms begin to appear. And then in the later stages, 5 and 6, is when the pathology spreads to the cortex and the higher level brain areas that affects cognition and may relate to psychosis developing as well. So a very complex series of events, not focused just on that motor area of the nigra, but more widespread within the brain. So we'll start with a discussion on cognitive features, and there are 2 things that we talk about when we see patients. There's MCI, mild cognitive impairment, also called mild neurocognitive disorder, which involves a modest change in memory and cognitive function compared to the previous level of function, but it's not at a level that interferes with daily function, at least at that point. And then there's dementia, which is a more severe or major neurocognitive disorder where they have more severe changes in cognition beyond what the person was beforehand, but now it's beginning to interfere with daily function and require assistance with activities of daily living. So this pie chart shows you the frequency of dementias of different types, and you can see in the purple part, Alzheimer's is the most common that we see, but it's marked dementia with Lewy bodies, but that's any Parkinson-related dementia is the third most common form of dementia that we see in practice. And dementia is not related to just a single phenomenon in Parkinson's patients. So I call this the rule of thirds, where 1/3 of patients develop Parkinson's disease develop dementia later in Parkinson's disease, and the dementia is caused by lower brain regions that make a chemical called acetylcholine. Then there's another third that just have concomitant Alzheimer's disease associated with it, two very common disorders that occur with age. And then the third is dementia with Lewy bodies, in which the dementia tends to occur earlier in the course of disease, and I'll talk to you a little bit more about that. So the dementia occurs for several different reasons in people with Parkinson's disease. Now, mild cognitive impairment is fairly common. About 20 to 50% of patients have it, and about a quarter of patients have it right at the beginning when they start noticing motor symptoms of Parkinson's disease. It is a risk for developing dementia later in life, and on this slide it says that about half patients may develop dementia within 5 years of developing mild cognitive impairment, but not everyone does, and at least 20% can revert back to normal, and those are 20% where cognitive changes are the result of medications or illness or depression or other issues that can be treated in patients. Dementia is more common in Parkinson's than the general population, and with Parkinson's disease dementia, as I showed you in the later, it occurs more in the later stages, it's usually after about 10 years. But the most important risk factor of developing dementia in Parkinson's disease and in everybody else is age. Age really is the major driver in developing dementia in the population as a whole. And the prevalence of dementia in PD is about 40% overall. Now, what's the difference between Parkinson's disease dementia and Lewy body disease, or dementia with Lewy bodies? This, by the way, is a picture of Frederick Lewy, who was the first one to describe Lewy bodies. He was in Germany pre-World War II working with Alzheimer, and he discovered these changes in the brain and wrote about it in 1913. He ended up leaving Germany prior to World War II as the Nazis took over, and ended up being an anatomy professor at the University of Pennsylvania, where he lived out the rest of his life. But Lewy body dementia has been described since the 1970s, and these are the key characteristics of Lewy body dementia. So the central feature being cognitive decline, and then other features are fluctuating cognition, which means that the person can have very lucid, clear periods and then very foggy, confused periods, and they're not predictable in the way they occur. They can have visual hallucinations even without being treated with medications, and they have, if you look under suggested features, they often have this disorder called REM sleep behavior disorder, which is patients acting out their dreams, and the dream content becomes more violent and threatening, and they start punching out and kicking. Sometimes they jump out of bed because they think they're jumping out of a window or escaping. And this is a very important characteristic of not only Parkinson's disease, but more commonly Lewy body disease. Now, Parkinson's disease dementia can look exactly like this. So the difference that we have is really an arbitrary difference, and that is that there's a thing called the 1-year rule for Lewy body disease, which is that the cognitive change occurs within 1 year of the onset of the motor features. That's Lewy body disease. With Parkinson's disease dementia, it's after a year, the onset. But the other symptoms can be very similar, and actually the brains actually look very similar in both groups. Now, what do we measure to recognize cognitive features? And these are the domains that are measured when we do testing: memory, language, executive dysfunction, visual motor abnormalities, and attention. And in Parkinson's disease, the most common abnormalities are executive dysfunction and visual motor processing speed. Visual motor meaning being able to see things correctly in a spatial way. And so those are the things we see most. We don't see memory abnormalities like we see in Alzheimer's disease, and I'll tell you a little bit about that. So this is the Montreal Cognitive Assessment. This is what we call a bedside test. It takes about 10 or 15 minutes to do, and we can sort of do a screening in order to see if there are any issues associated with cognitive change in patients, and a score of 25 or higher is considered to be normal. But sometimes we are more worried and we want to do more detailed testing, so we do a series of other tests that can take 2 or 3 hours. I'm sure some of you have gone through these tests. So I'll just show you a couple of them. So for executive functioning, there's a thing called set shifting. Set shifting is when you change your attention from one thing to another thing and then back again. And people with Parkinson's tend to have trouble doing that. That's what executive dysfunction really measures. And then there's conceptualization, this notion that you can hear an idea and you can describe it or write it down. So I'll show you some tests on how to do that. So this is called the TRAILS-B test, and this is for set shifting. And what it does is it gets you thinking about numbers and letters, and you alternate. So you do a dot to dot, and it's you go from number to letter to number to letter to number to letter, etc. And that's the norm. This is a normal response to doing that TRAILS test. And we not only look at whether you do it correctly, but we look at how quickly you can do it. And this is a person with dementia who had significant problems performing this test and was unable to really switch well and appropriately to that. Now, conceptualization is having people draw a clock. Doing a clock test, you have them draw a circle with the clock and put the numbers in it, and then you ask them to put the hands up so that it says 10 minutes after 11. And someone with mild cognitive impairment might do this, where if you look up at the 11 and 12, they didn't put the hands in, but they marked where the hands might be with a bunch of hash marks. So this would be an incorrect response. And the next one is someone with severe dementia who was even unable to utilize the circle in order to create the clock appropriately. Now, doing memory testing can help us differentiate from Alzheimer's disease, as I mentioned, and so there are a few tests that we can do for this, and I'll show you one. But in Parkinson patients, they have memory problems, but it's not that they can't make new memory, it's that they can make new memory, but they can't find it after they've created the memories, and they need cues or something to get them to bring out the memory. In Alzheimer's disease, people can't make new memory. So there's a test called the Hopkins verbal learning test, where patients read 12 words 3 times, and then they're asked to recall those words immediately and then in a delayed fashion, and then they're shown some of the words, and they're asked to tell the examiner whether those words were in the list or not. And so you can see in this graph, the dark bar is for immediate, and the light gray bar is for delayed. You can see that the PD patient on the right does much better than the patient with Alzheimer's disease on the left. And if you look at recognition where they're shown the words, the Alzheimer patients have fairly significant problems with that, but The Parkinson patients do exceedingly well. They remember almost 12 of the 13 when they're shown the words and make very few errors. The light bar is the errors that they make. So you can differentiate Parkinson's disease patients from Alzheimer's in that way. And then this is a test for visual spatial called judgment of line. And it's very simply, you look at the lines up on the top, the two broken lines, and you ask, which numbers do they represent in the pattern on the bottom below? And that'll demonstrate whether there's visual spatial problems. And we do these tests on a regular basis in patients who are having cognitive issues to help us make the diagnosis, differentiate them from Alzheimer's disease, and think about treatments. So when we have patients with dementia, the first thing we do is we lower medications or do away with medications that can alter cognition, and they include anticholinergics, dopamine agonists. We treat them for depression. Low blood pressure can make your memory foggy, and we do a variety of other things, including using cholinesterase inhibitors, which were developed for Alzheimer's disease, and atypical antipsychotics, which are used for hallucinations. And this is a listing of those drugs that are available. Unfortunately, they're very modest in effectiveness, but they do help some people, and they shift the curve over a little bit. But I will tell you that there's hope. If you look at clinicaltrials.gov, there are at least 5 new classes of drugs that are currently being investigated for dementia and Parkinson's disease. So let's go on to psychosis now, which is related to this. And psychosis is a major psychiatric illness in which reality testing is impaired, typically with hallucinations and delusions. Hallucinations are perceptions without a stimulus. That is, maybe you see a person sitting on your couch or someone walking through your living room. An illusion is when you see a lamp and that looks like a person. So there's a stimulus, but it's misperceived. And then delusions are false beliefs, usually paranoid in nature. So there are several kinds of hallucinations. And so there are minor ones, and you can see the list there. So presence hallucination is not really something you see, but it's a feeling like somebody is next to you or near you. And you don't see them, you don't hear them, but it's just a sense that they're present there. Passage hallucinations is when you are looking at something and you think you see something go past you. It could be a person, it could be an animal, it could be almost anything, and then you turn and they're not there. And those are very brief, and then illusions we mentioned. But hallucinations, visual hallucinations are the most common. They're usually people. They can be distorted. They can be shadows. They can have faces or not have faces. And they usually don't interact with the person. They just see them there. And if you go over to touch them, they disappear. And there are auditory hallucinations, which are not like schizophrenia, where schizophrenia, they hear voices talking to them. These hallucinations are more like hearing music in the background or hearing like a group of people, like the hum of a crowd in the background. And those are actually more common than previously thought. This is just some pictures. Joe Friedman, a neurologist from Brown University, provided me that some of his patients gave him. And so the right one is an illusion where the person is seeing faces in a plant. And the other one, the left one, is a hallucination, someone seeing a face in their yard, a person in their yard. Delusions are less common, but they are more severe and can lead to hospitalization. Most commonly, they're paranoid delusions, fear of being injured or poisoned. They think there are elaborate conspiracies against them. And a very common one is spousal infidelity, often called Othello syndrome. And some people have delusional misidentification syndrome, where they think their caregiver has been replaced by an imposter, and they don't want to deal with them because they think they're not the real person. Now, I've sort of perceived psychosis in this manner, and I'll sort of walk you through this very quickly, but the causes of psychosis are many, and there is not just one Psychosis for Parkinson's disease. And so if you look over to the left, the one that says symptomatic, that's green, that's usually for people who have infections or medications that are causing the hallucinations, and you can treat them by removing the cause or treating their infections. The circle in blue is from medications. The PD medications can often cause hallucinations, and removing them or lowering the doses can make those go away fairly simply. The one in orange on the right is associated with mood disorders. So these people have depression with psychotic features, and they can be sometimes treated with antidepressants instead of antipsychotic drugs. And then the yellow one is associated with cognitive decline or dementia. They're the hardest to treat, and they can be treated sometimes with antipsychotics and sometimes with dementia therapies like anticholinesterase inhibitors. So I'll skip that. And this is how we treat it. So at first we just simplify medications. Of course, before that we look for any secondary symptomatic causes, and then we reduce their medications, and if that doesn't work, then there are 3 medications we use. Pimavanserin is the only one that's available that's FDA approved for hallucinations, and that's the one with the scary commercials that you've seen on TV. And then there's quetiapine and clozapine. And clozapine is probably the best drug, but it's limited in its use because it can cause white blood count changes, and patients have to have blood monitoring initially every week and ultimately at least monthly. So that one is used the least, but it has the most evidence available for its use. We'll talk about depression now, depression and anxiety. So depression is a symptom of Parkinson's. It's not a reaction to getting Parkinson's disease, although it can be that too. And it's present in about 50% of patients who have Parkinson's disease. And how we bring that out varies. So on the third bullet, there's a thing called a SCID, S-C-I-D, and that is a structured interview that psychiatrists do to bring out depressive symptoms. And then BDI under that is a questionnaire that the patient answers called the Beck Depression Inventory. And you can see from the percentages that they have different capabilities of bringing out depression in patients, but they both can be very helpful in being used. Depression is more common in patients than in the healthy elderly population, more common in Parkinson's disease than other chronic diseases like diabetes and osteoarthritis. And as I showed you, it can be a very early sign, even a premotor sign of Parkinson's disease. And this slide shows you, if you look at the pie chart there, the green is major depression, and that makes up about 40%. And the blue, the royal blue, is no depression. So the other smaller groups are different types of depression that are seen, including even a small number with bipolar affective disorders. These are the symptoms of depression that we see. It's not just mood change and feeling sad or hopeless, but anhedonia, which is an inability to experience pleasure, apathy, which is decreased motivation, no desire to, or interest to do anything. But other things are insomnia, fatigue, poor concentration, decreased facial expression, which we see in Parkinson's disease also, decreased movement, and even changes in voice. So there's a pretty widespread number of symptoms that can relate to depression. And the diagnosis is missed often. Lisa Schulman and her group a couple of decades ago found that 35% have a misdiagnosis, and about half the patients don't even know they're depressed when they have depression. And even when we look at treatment, you can see that about in the gray area of the pie chart, almost 30% of patients who have depression don't get treated. Often patients tell us, I don't want to be on those medicines, but oftentimes it's because we don't recognize that they're depressed. But it's really important to treat because it has a huge impact on all of your Parkinson's disease. And in the green area, even in those who are treated, many of them are undertreated and don't get a large enough dose or appropriate medication for treatment. Now, anxiety is an unpleasant sense of apprehension, kind of like I had before I came up here today when I saw how big this group was. There are several types of anxiety that you can see that are listed: generalized anxiety disorder, social phobia, panic disorder, and others. And I'll talk about just a couple of those. So generalized anxiety disorder is just excessive anxiety and worry about various activities. The symptoms are present for many months, and you can see that patients who have this are restless, have fatigue, concentration abilities, irritability, sleep problems, very similar to what you see with depression. Social phobias are marked by social situations that make people anxious. So in Parkinson's disease, who have freezing, going out in public and walking in public or eating and drinking in public can invoke fairly significant anxiety in patients, and so they don't like to go out very much. So anxiety is common. About 50% of patients will have it. They don't always meet criteria for the diagnosis, but they clearly have anxiety-like symptoms. And you can see with the different measures that they bring out anxiety in different ways, just like with depression, doing the SCID or the Beck Anxiety Inventory. Now, panic attacks are discrete attacks of fear, sometimes making someone feel like they're going to die. And they're often part of that wearing off that Dr. Dewey talked about. And it's often associated with depression. And the list of symptoms is broad, but they get palpitations and trembling and upset stomach and urinary frequency and chest pain and motor freezing, and fear of dying is a big part of that. And they mostly occur again in off periods. And anxiety and depression go together significantly in the general population and in Parkinson's disease. So to treat it, we usually try to treat fluctuations for patients. Seeing a counselor is very helpful for treating depression and psychosis. Doing cognitive behavioral therapy can be very helpful. Different medications, SSRIs and SNRIs, are very helpful, and in extreme cases, transcranial magnetic stimulation or ECT can be utilized to treat patients. I'm going to skip that. This is a list of the medications. You'll recognize many of these that are used. They're SNRIs and SSRIs, and they're both helpful. And this was a study, a large study done in Parkinson's patients, demonstrating that both classes of medications are very effective in treating depression and anxiety in patients with Parkinson's disease. And I think I've run out of time, so I'll just stop here. Thank you very much.